So now coming to the lab diagnosis, lab testing and the diagnosis in cases of syphilis. So what are the testing methods? So direct testing methods such as dark field microscopy and polymerase chain reaction. So you can have a direct testing of the organism by these two techniques. One is a dark field microscopy and second is a polymerase chain reaction. So let's see the advantages and disadvantages of each. Okay, for dark field microscopy you require a expert observer, okay, performed by the experienced observer, and DGI is less reliable in examining rectal and non-penile genital infections, and it is not suitable for examining oral lesions due to the presence of commensal trypanomes. Okay, so dark ground illumination or direct dark field microscopy is has got a limited role when you have a rectal and non-penile genital lesions, and it is not suitable for oral lesions because many commensal trypanomes are present, and that will not be able to differentiate Trypanoma pallidum from the other trypanomes. Okay, but advantage is that it gives quick results, detects the bacteria before a serological response, and the second test, that is polymerase chain reaction, it can be used on oral and other lesions where commensal trypanomes are also present. Okay, so the disadvantage of dark field microscopy can be overcome by these PCR, where it can be used for oral as well as other lesions where commensal trypanomes are also present, and in certain circumstances PCR may be helpful in diagnosis by demonstrating Trypanoma pallidum in tissue samples such as vitreous fluid, CSF, etc. But disadvantage is that it is available only in the reference laboratories. Okay, so for direct testing methods we have two things. One is a direct or dark field microscopy, and second is a polymerase chain reaction. Okay, now coming to the serological test. Serological test is also very important from examination point of view. So please concentrate on these particular figures. We'll enumerate the various tests which are available. Then we will see what are the SOPs, how these tests are used for the diagnosis of syphilis. Okay, so first we'll go through what are the different tests which are available. So trypanomal antibody test cannot differentiate between syphilis caused by the Trypanoma pallidum from the endemic trypanosomes such as other diseases like yaws, Beagle and Pinta. So when you have an antibody test, but this antibody test which will not be able to differentiate between the Trypanoma pallidum causing syphilis and other endemic trypanomatosis, that is yaws, Beagle and Pinta. So trypanomal antibody test, they can be classified into two. One is a non-specific test and second is a specific test. So specific test will be specifically for trypanoma, while non-specific test, these are cardiolipin or lipoidal or reagin or non-trypanomal test, in which we have VDRL, that is Venereal Disease Research Laboratory carbon antigen test, and other is a RPR test. So RPR and VDRL are non-trypanomal test. Okay, so RPR and VDRL are non-trypanomal test, while specific test or trypanomal test are EIA, CLIA, TPPA, TPHA, FTABS and Trypanoma pallidum immunoblot. Okay, so EIA, that is trypanomal enzyme immunoassay, then trypanomal chemiluminescence assay, that is CLIA, TPHA, that is Trypanoma pallidum hemagglutination assay, then TPPA, that is Trypanoma pallidum particle agglutination assay, FTABS, fluorescent trypanomal antibody absorption test, FTABS, and Trypanoma pallidum immunoblot. Okay, so when you have these many tests, we need to know which test and at what time we have to use this. Okay, so subsequent slides will be related to these different tests. Out of it, just remember FTAB is not recommended, so do not select the option if it is a EMQ or SBA question as FTABS. Okay, and another thing is that out of these specific trypanomal tests, TPHA and TPPA, it is TPPA is preferred over the TPHA. Okay, Trypanoma pallidum particle agglutination test assay will be preferred over the TPHA. Okay, now let us see how these tests are used. Okay, so these tests are based on recombinant trypanomal antigens and detect trypanomal IgG and IgM antibody. Trypanoma pallidum specific IgM antibody tests are anti-trypanomal IgM EI and immunoblot. So these are IgM antibody test, anti-trypanomal IgM EI and immunoblot. Okay, now all these serological tests are divided into two: primary screening test and confirmatory screening test. Okay, so depending upon its uses, these tests are categorized into two: One is a screening test and second is a confirmatory test. So initially we have seen the types of test, that is treponemal test and non-treponemal test. Okay, non-treponemal we had only two, that is RPR and VDRL, while treponemal tests were many. Okay, out of which we have mentioned that FTABs will not be our option. Okay, then we have EIA, CLIA, TPPA, TPH and immunoblot. Now let us see this classification, that is the tests which are used for screening and the tests which are used for the confirmation. Okay, now treponemal EIA or CLIA preferably test that detects both IgG and IgM, or TPPA which is preferred to TPHA. Okay, so in the screening we have four tests: EIA, CLIA, okay, and TPPA and TPHA. Out of TPPA and TPHA, the TPPA will be preferred over the TPHA. Okay, so these are the primary screening test. Okay, an anti-treponemal IgM test, if we suspect primary syphilis is suspected. So if we are suspecting primary syphilis, then anti-treponemal IgM test will be preferred. The clinical utility of IgM test is limited because of its suboptimal sensitivity, and it should not be used to stage the disease or decide the duration of the treatment required. Okay, so IgM has got limitation, that it has got a suboptimal sensitivity and it should not be used for staging the disease or decide the duration of the treatment required. Okay, now let us come to the confirmatory test. So positive screening test to be confirmed with a different treponemal test. Okay, so the primary screening tests are EIA, CLIA, TPPA, TPHA. So out of these are all treponemal tests, out of whichever test you will do, you have to use the other test for the confirmation. Okay, we'll see the flowchart in the subsequent slide. Then you have IgG immunoblot is recommended as a supplementary confirmatory test when the standard confirmatory test does not confirm the positive screening test result. So whatever the test we have used for the screening first, we will use other test for the confirmation. Okay, so we will use treponemal test first for the screening, then other treponemal test will be used for the confirmation. If the other treponemal test is not giving the confirmatory result, in that particular case we can use IgG immunoblot. Okay, so IgG immunoblot is recommended as a supplementary confirmatory test when the standard confirmatory test does not confirm the positive screening test result. The FDA ABS is not recommended as a standard confirmatory test, although it may have a role in specialist laboratory. So we have already seen out of those 6 tests, the FDA AB is not recommended as a standard confirmatory test. So that will not be our option in the answer. Okay, now let's see in the flowchart. Okay, so look at this particular flowchart. So what we are doing, when the patient comes for the booking, we are screening the patient. Okay, so the test what we are going to use a treponemal test. Okay, the treponemal test which detects both IgG and IgM we are going to use, and the tests are EIA, CLIA, TPPA or TPHA. Out of TPPA and TPHA, we are going to prefer TPPA. Okay, so out of these particular tests, we will use one test. Suppose either we can use EI or CLI on the sample, and if the test is positive, okay, in that particular case, what we have to do? The same sample on which EI or CLI test has become positive, on the same sample, we have to use different test. For example, we will use TPPA. Okay, on the same sample, we are doing the other test, and we will also take the new sample from the same patient and we will perform the same previous test, the first test, that is EI or CLI. So first we have done the EI or CLI, it was positive. So on the same sample we have done the TPPA. Okay, and we have taken the fresh sample, and on the fresh sample again we have performed the first test, that is EI or CLI, and if both these tests will give the positive result, then we confirm that this is syphilis. Okay, so that will be the confirmatory test. Okay, confirmation of the diagnosis. Okay, so clear this much. And in the previous slide we have mentioned, if the standard confirmatory tests are not able to confirm the diagnosis, then we can use IgG immunoblot. But in general, EI, CLI first test, if it is positive, on the same sample we will do the TPPA. Okay, On the new sample from the same patient, we will carry out again the EICLI, and if all these tests are positive, we will confirm that it is positive. Once we confirm that it is positive, we will carry out RPR or VDRL test, so that will come to know the antibody titers before starting the treatment. So that will give us the baseline titer, okay, and we will measure this titer 3 monthly. So the what we can measure is the severity of the disease as well as the response to the treatment we can measure by VDRL or RPR test. I hope this is clear to you. What is the role of different tests? So RPR and VDRL, these are non-treponemal tests. The role of these non-treponemal tests is mainly monitoring the disease activity and response to the treatment, while diagnosis is by treponemal test, okay, and they are performed in sequence whatever I have mentioned. So not only that, what we have to do additional, we will refer the patient to the GUM clinic, that is genitourinary medicine and pediatric and neonatal care, to commence the complete batch congenital syphilis birth plan. So we have to formulate the birth plan for this pregnant lady, okay, by referring her to the GUM clinic, and we have to coordinate with the pediatric team also. Now, if the patient is from low risk category, this is more than sufficient. But if your patient is high risk, then we have to offer the repeat screening in certain cases, and that repeat screening will be 3 monthly. Okay, if the patient has or the woman has declined at booking the initial screening, if she has declined, then we will offer this screening at 3 months again. Again, this is SBA. There will be scenario in which the such and such lady has come for the booking, and she has declined the screening for the VDRL. So what will you do? So we have to offer the screening after 3 months. And if any of the following risk factors are present for a high risk exposure, such as new or multiple sexual partners, she is commercial sex worker, or sexual contact with MSM, or sexual partner is from a country with high prevalence such as Africa, Southeast Asia, or South America. So if the patient is from this particular high risk areas or category, in that particular case, we have to repeat the test 3 monthly. I hope this is clear to you. Okay. So there can be scenario that such and such a patient is from such and such category, or in that particular, what is the next step, and her initial report may be given that it is negative. Then what we will do, we will carry out subsequent screening after 3 months. Okay. So now we have seen, once the primary screening is positive, what we do, we second specimen should always be tested to confirm the positive results, and on the day of treatment is commenced, we find out the RPR or VDRL titers. Okay. Now, what are the tests for assessing the serological activity? Serological activity, the test is a quantitative RPR or the VDRL. It should be performed when the depenemal test indicates syphilis, as this helps to stage the infection and indicates the need for treatment. Patient has been previously treated and may have been reinfected. So, quantitative RPR and VDRL is recommended for assessing the serological activity of the disease. Okay. So, initial RPR or VDRL titer more than 16 usually indicates that it is an active disease and the need for the treatment. So please remember, the titer, significant titer, is VDRL or RPR titer of more than 16 usually indicates the active disease, but the corollary is not true. What does it mean? VDRL or RPR titer of 16 or less does not exclude the active infection, particularly in a patient with clinical signs suggestive of syphilis, or where adequate treatment of syphilis is not documented. So if you have a VDRL titer or titer is low, that particular thing does not mean that there is no active disease. However, if the VDRL or RPR titer is 16 or more, that indicates active disease. However, previously we have done the screening test, confirmatory test, and then we have measured the titer. Okay. And if it is more than 16, it is an active disease and there is a need for treatment. However, less than 16 titer or 16 titer does not rule out the active infection, especially when there are clinical signs suggestive of syphilis or where adequate treatment is not documented. Okay. And negative antitepanal IgM test does not exclude active infection, particularly in late disease. So if you have a late disease, in that particular case, even IgM is negative, that also does not rule out the infection, because in late disease, IgM test might come as a negative even if the patient is a case of syphilis. Okay. So what are the tests for monitoring the effect of treatment? Again, the quantitative RPR and VDRL test is recommended for monitoring the serological response to the treatment, and it should be performed on a specimen taken on the day and when treatment is started, as it provides accurate baseline monitoring. So when before starting the treatment, we carry out the VDRL and RPR, and that will be the baseline titer, and monitoring will also be done by the VDRL and RPR titer. Okay. Now, when the repeat screening is recommended, now if the patient has got only single high risk exposure, the patient has got only once high risk exposure and initial test is negative, then what we can do? We can do the 6 weeks, we can repeat the test at 6 weeks and 12 weeks after the single high risk exposure. Okay, such as there is unprotected oral or anal or vaginal intercourse with homosexual male, or multiple partners, or anonymous sex encounters. In that particular case, and if it is a single episode, we'll repeat the test at 6 weeks and 12 weeks after the single high risk exposure. Okay. Now, if the exposure is continuous, if there is a risk behavior which is ongoing, in that particular case, in individuals at ongoing risk due to frequent high risk exposure as defined above, screening as a part of routine sexual health checkup for all STIs including HIV and others is recommended usually every 3 months and informed by the sexual history. So in that particular case, we have to carry out the battery of the test for all STIs including the HIV, and we will repeat every 3 monthly if there is a continuous exposure or continuous high risk exposure. Okay. And if your initial test is negative, such as dark field or PCR is done and there is an ulcerative lesion, in that particular case we will repeat the test after 2 weeks. So you have got a lesion, or say primary chancre, you have done the dark field microscopy and the test is negative, or you have done the PCR and it is negative. Okay, and you are suspecting there is a case from high risk category, in that particular, so you will repeat the test after 2 weeks. Okay. So let's see about false negative syphilis serology and the false positive syphilis serology. When we are likely to get false negative result, okay, that means there is a disease but the test is positive, test is negative. So trypanosome screening tests are negative before chancre develops and maybe up to 2 weeks afterwards. That is why there is a lesion and your dark field microscopy is negative, we are going to repeat after 2 weeks, or PCR negative, we will repeat after 2 weeks, because trypanosome screening test will be negative for before chancre develops and maybe up to 2 weeks it may remain negative. Okay, so we have to repeat the test. Second, a false negative RPR VDRL test may occur in secondary or early latent syphilis due to prozone phenomena. So in secondary syphilis or early latent syphilis, the VDRL and RPR can be falsely negative, and this is because of prozone phenomena. Again, this is one of the SBA or EMQ. When testing in undiluted serum, you have done the testing, VDRL and RPR is negative when you have tested the sample in undiluted serum. Okay, in such cases, negative test on undiluted serum we have to repeat with a serial dilution. Okay, so we will be diluting the serum serially and will carry out the test, and the test will become positive in on the diluted sample. Okay, this is called as prozone phenomena. This may be more likely to occur in HIV infected individuals. So prozone phenomena is one of the conditions in which we are likely to get the negative serology, and that will happen in secondary syphilis or early latent syphilis. Okay, and third, VDRL, RPR and IgM may be negative in late syphilis. Okay, so these are the conditions in which we can get a false negative syphilis serology. Now let's see when the false positive syphilis serology we can get. That means there is no syphilis but the test gives false positive result. So there are no symptoms of syphilis, there is no history of syphilis, or there is no concomitant positive anti-trypanosome IgM, but there is a transient or persistent reactivity in a single trypanosome antigen test, and it should be considered as a false positive result. So you have only single trypanosome antigen test which is positive, however there is no symptom, the patient is from low risk category, there is no history of syphilis or concomitant positive anti-trypanosome IgM. In that particular case, it is likely to be a false positive result. I hope this is clear to you. Okay, so screening test, confirmatory test we have seen. Okay, now coming to the recommendations. An EI, CLI, preferably detecting both IgG and IgM, is the screening test of choice. This we have seen. Then positive screening test should be confirmed with a different trypanosome test. such as TPPA or TPHA. TPPA is preferred over the TPHA. FTAB is not recommended, and second specimen for the confirmatory testing should be obtained. So we have to obtain another specimen also, and we will perform the test. A quantitative RPR or VDRL should be performed when screening tests are positive. Repeat negative serological tests for syphilis. Okay, when we are going to repeat at 6 weeks and 12 weeks after isolated episode which is high risk for exposure to the syphilis, then 2 weeks after the possible chancres that are negative for the dark ground or PCR which is negative, then we will repeat the test after 2 weeks. Okay, these are what are the recommendations. Now we have seen the diagnosis, we have seen various tests for the syphilis, how we are going to carry out, and the flow chart showing the use of the different tests for the diagnosis. Now let us come to the treatment. So now we will see further treatment during the pregnancy, and then we can see the treatment in a non-pregnant status. Okay, most of the treatment is same, only certain drugs which are not safe in the pregnancy can be used in a non-pregnant status. Again, here there are so many SBAs and so many EMQs in next 2 to 3 slides, so please concentrate. Okay, now this particular chart shows when you have an early disease. Okay, early disease, the drug of choice is a benzathine penicillin. Okay, benzathine penicillin intramuscularly 2.4 mega unit single dose when it is an early disease and the patient is in the first or second trimester. However, when the patient is in a third trimester and it is an early disease, you have to give one more additional dose after 7 days. Okay, so day 1 and day 8, benzathine penicillin is a drug of choice. Okay, and 2.4 mega units to be given intramuscularly. Okay, third trimester, 2 doses, day 1 and day 8. Now, if the disease is a late disease, then irrespective of the stage of the pregnancy, you have standard regime, 3 weekly, 1 dose for 3 weeks. Okay, same drug, benzathine penicillin, 2.4 mega unit intramuscularly weekly for 3 doses. Okay, so our regimen depends upon one, whether the diagnosis is early syphilis or it is a late syphilis. Okay, so early syphilis, that is you have primary syphilis, secondary syphilis or early latent. In that particular case, the single dose regimen if the patient is in the first or second trimester, and 2 dose regimen if the patient is in the third trimester. And in late disease, that late latent and late disease, you have weekly injection benzathine penicillin for 3 weeks. Okay, so the standard treatment for early disease by WHO is a start dose of intramuscular benzathine penicillin G 2.4 mega units. A second dose is recommended when treating early disease in the third trimester because there is a low serum levels of the drug and the risk of treatment failure. Okay, for patients who are sensitive to penicillin, who can tolerate cephalosporin, the alternative is ceftriaxone 500 milligram intramuscularly for 10 days. So you may get a scenario in which it is mentioned that the patient is sensitive to penicillin. Okay, then what is the drug of choice? If the patient can tolerate ceftriaxone or cephalosporin, that in that case we can use ceftriaxone 500 milligram intramuscularly for 10 days. Okay, so the drug of choice is a ceftriaxone if the patient is sensitive to the penicillin. Okay, but tolerating the cephalosporin. If the patient is not tolerating the cephalosporin also and sensitive to penicillin, in that particular case we have to go for desensitization. Okay, now you have a patient who is not allergic to the penicillin but unable to tolerate intramuscular regime. Something like a patient has got a needle phobia. They don't want the intramuscular or injectables. So in that particular case, and the patient is not allergic to the penicillin, so what we can use amoxicillin 500 milligram along with probenicid 500 milligram, both to be given orally 4 times a day for 14 days. Remember, when we give oral treatment in early disease, we have to treat for 14 days. When we use benzathine penicillin, it is a single dose regime. In the third trimester, we will give 2 doses. Okay, when we treat orally, then we will treat for 14 days. Okay, not allergic to the penicillin, amoxicillin can be used orally. okay, in patients who does not want injectable. Now, the treatment of maternal syphilis at least 30 days before delivery will reduce the risk of congenital infection and perinatal mortality. This is very important. How many days before the delivery we should treat the patient or complete the treatment? At least 30 days, so that the risk of the congenital infection and perinatal mortality will be reduced. Okay, this is also one of the SBA that can be asked. In light of increasing macrolide resistance to the by the Treponema pallidum and the inability of the macrolide antibiotics to cross the placenta in adequate quantities, macrolide antibiotics such as erythromycin and azithromycin have now been removed from the batch guidelines. So we will not be selecting these options such as erythromycin, azithromycin. These are macrolide group of antibiotics, and they do not cross the placenta in adequate quantities. Okay, so you have understood this. Benzathine penicillin is the drug of choice. Okay, the patients who are allergic to the penicillin but tolerating the cephalosporin will use ceftriaxone. Okay, but the dose is 500 milligram for 10 days. So injectable is a single dose penicillin, or alternative will be ceftriaxone, provided patient is tolerating the cephalosporin. Okay, when we go for oral treatment, but the patient should not be sensitive to the penicillin. Patient should tolerate the penicillin, then orally we can use amoxicillin along with probenecid. Okay, and the treatment should be completed 30 days prior to the delivery. Now, this is also one of the important slide, that is Jarisch-Herxheimer reaction, and this is also one of the SBA which can be asked. So Jarisch-Herxheimer reaction, it develops during the treatment of syphilis and seen in 45% of syphilis treatments in pregnancy. Okay, this is associated with the large number of Treponema pallidum being killed, which in turn releases excessive cytokines leading to an acute inflammatory reaction. So it is the inflammatory reaction which is induced by the cytokines because of the large number of Treponema pallidum are being killed. Okay, and almost in 45% of pregnant patients who are treated for syphilis, you see this Jarisch-Herxheimer reaction. Symptoms will typically occur within first 24 hours of the treatment, and it will include fever, rigor, skin rash. In pregnancy, there can also be uterine contractions which are induced by this reaction, and the reaction is particularly common during the management of the early disease. Okay, so it's very common in early disease. So by comparison, the latent disease has got a reaction rate of only 25%. So if the patient is in the latent disease, then the reaction rate is only 25%. Overall, in pregnancy, we have noticed that it is a 45% pregnant patient can have this reaction during the pregnancy when the treatment is started. However, if the patient is in the latent disease, in that particular case, there can be 25%. Then 50% chance if the patient is primary syphilis, and as many as 90% chance of Jarisch-Herxheimer reaction if the patient is a case of secondary syphilis. So secondary syphilis has got a highest chance of developing Jarisch-Herxheimer reaction in 90% of cases. The Jarisch-Herxheimer reaction are highly variable and generally self-limiting. Therefore, there is no recommended treatment regimen, and aside from fluids, supportive care, symptom control, opioids, paracetamol, hydrocortisone, these drugs have been tried 1 to 2 hours before and after administration of antibiotics to prevent or reduce the severity of the reaction. However, the results were not sufficiently beneficial to be universally recommended. So there is no evidence-based recommendation for the use of opioids, paracetamol or hydrocortisone either before or after treatment has been started. Okay, they have been tried. Okay, but there is no universal recommendation for that. Okay, now let's see about the recommendations. All pregnant Now let's see about the recommendation. All pregnant women should have a syphilis serology at their first antenatal clinic visit, and if the risk of syphilis is recognized, rescreening later in pregnancy should be offered. When women have been cured of syphilis prior to the pregnancy and are not at risk of reinfection, the neonate will not require testing. Okay, so if the disease is cured before the pregnancy and they are not at risk of reinfection, the neonate will not require testing. Retreatment in pregnancy is indicated where there is uncertainty of treatment or serological cure is in doubt. So if there is a previous history of treatment, but we may have to treat the patient where it is uncertainty of the treatment or serological cure is in doubt. Okay, but if the lady is completely cured prior to the pregnancy, then there is no need for the neonate for the testing. And when treatment for early syphilis is indicated in the third trimester, a second dose of benzathine penicillin 1 week after their first dose is recommended. So this is all what we have seen in our previous slides. Now let's go further. For those who are allergic to the penicillin, desensitization should be considered. Where it is necessary to use macrolides to treat the mother during the pregnancy, the neonate will require assessment and treatment at birth. Okay, so macrolide antibiotics are not recommended. For some reason, macrolide antibiotics are used to treat the mother during pregnancy. In that particular case, neonate will require testing and assessment because they do not cross the placenta adequately. Okay, the management should be in conjunction with the fetal medicine and pediatric colleagues. Routine use of steroids to prevent the Jarisch-Herxheimer reaction is not recommended. So there is a multidisciplinary team involvement in managing the case. The gum clinic, gum consultant is involved, fetal medicine and pediatric colleagues are to be involved, and syphilitic birth plan is to be formed. Okay, and maternal diagnosis and treatment should be clearly communicated to appropriate obstetrician, GP, pediatric team with informed consent. A template birth plan is provided. Okay, now coming to the treatment. Okay, these particular charts are taken from the UK guidelines on syphilis in 2015 publication. Okay, now this is pregnant as well as non-pregnant or mainly non-pregnant status. So certain drugs, what we have seen is the benzathine penicillin and all, we have finished with the treatment during the pregnancy. So in general, treatment, what is recommended in early syphilis, in late syphilis, that we will see. Okay, so early, that is primary, secondary or early latent syphilis, same what we have seen in pregnancy, the same treatment is recommended, that is benzathine penicillin 2.4 mega unit single dose. Okay, alternative regimens are procaine penicillin 6 lakh unit per day for 10 days. Okay, then doxy can be used, doxycycline orally for 14 days. Remember, oral treatment is for 2 weeks. When benzathine penicillin is used, it is a single dose regimen. In third trimester, we will give 2. In late, we will give weekly for 3 doses. When we go for procaine penicillin injectable or ceftriaxone, because the patient is sensitive to penicillin, we will give injectable for 10 days. When we will go for oral treatment, any drug for 2 weeks in early disease. Okay, so doxycycline, this is for non-pregnant status. The dose is 100 milligram. Remember 100 milligram because we will see the dose in neurosyphilis, it is 200 milligram and the duration is also 28 days. Okay, so in early syphilis, doxy is recommended 100 milligram BD for 14 days. Other ceftriaxone we have already seen 500 milligram intramuscularly daily for 10 days. Injectable apart from benzathine penicillin treatment 10 days, oral for 2 weeks. Amoxicillin is to be used along with probenecid 500 milligram QDS for 2 weeks, and azithromycin and erythromycin are not preferred. Okay, then coming to the late latent, that is again benzathine penicillin can be used weekly for 3 doses, and alternative will be same procaine penicillin. However, treatment is for 2 weeks, that is 14 days. We have seen 10 days in early syphilis, but in late syphilis we have to give injectables apart from benzathine. Whatever we will use is for 2 weeks. So procaine penicillin will be given for 14 days. Doxy dose is 100 milligrams, same, it is to be treated for 4 weeks. Late disease is to be treated for 28 days. Okay, and amoxicillin 2 gram per oral TDS. Here the amoxicillin dose is also increased. Instead of 500 we are using 2 gram TDS plus probenecid 500 milligram QDS for 4 weeks, that is 28 days. Okay, and remember steroids should be given with all antitrypanomal antibiotics for cardiovascular and neurological syphilis. 40 to 60 milligrams of prednisolone OD for 3 days starting 24 hours before the antibiotics. So this is recommendation for when we are treating the cardiovascular or gametous cardiovascular or neurological syphilis, then steroids is indicated. Prednisolone 40 to 60 milligram is recommended. So if you have a EMQ in that particular case, and if it is a treatment for the late disease, please select this option where they have given the steroids, okay, along with the antibiotics. So it should be started 24 hours prior. Okay, now you have seen, notice that the oral treatment dose in early syphilis is for 2 weeks and oral treatment dose is for 4 weeks in late disease. Okay, now let us go to the neurosyphilis. In neurosyphilis, the procaine penicillin and benzathine penicillin. So the first recommendation is for procaine penicillin here. The dose is high, that is 1.8 to 2.4 mega unit IM plus probenecid 500 milligram QDS for 14 days. So neurosyphilis is to be treated injectable by for 14 days. Okay, that is 2 weeks injectable. If we use benzathine penicillin, again the dose is high, that is 10.8 to 14.4 gram daily, given as 1.8 to 2.4 gram intravenously 4 hourly for 14 days. Okay, and here remember the doxy dose is 200 milligram BD for 28 days. Okay, so in early disease doxy was 100 BD for 2 weeks. In late disease doxy was 100 BD for 4 weeks. Here doxy is 200 BD for 4 weeks. Okay, amoxicillin again high dose 200 TDS along with probenecid to be treated for 28 days, and ceftriaxone 2 gram intramuscularly is used. Here ceftriaxone dose is also high in neurosyphilis. So this is what is the next is the treatment of syphilis in pregnancy. We have already covered, so I will not go into the detail. Now the only thing we have not seen previously is a congenital syphilis treatment. Okay, so for the neonate, if the congenital syphilis is diagnosed, then the benzyl penicillin is the drug of choice, 60 to 90 milligram per kg, given daily intravenously in divided doses. So how it is given? 30 milligram per kg 12 hourly in first 7 days of life, and then it is given 8 hourly for 10 days. So benzathine penicillin is the benzyl penicillin is the drug of choice for congenital syphilis. Okay, benzyl penicillin 60 to 90 milligram per kg. Okay, for first 7 days the BD dose, and next 7 day it is a TDS. Okay, total treatment is for 10 days. Alternative is a procaine penicillin 50,000 international unit per kg for 10 days you can give. Okay, so congenital syphilis also treatment we have covered. Now management in pregnancy, general considerations are serological screening for syphilis at their first antenatal assessment. Test should be repeated later in pregnancy if a woman has been at risk of infection after a negative initial screen. Adverse pregnancy outcomes in syphilis will include, although there is a fetal infection which usually occurs late in pregnancy, it has been demonstrated as early as 8 to 9 weeks of gestation. This may result in polyhydramnios, miscarriage, preterm labor, stillbirth, and head drops. Edema in 2 or more fetal compartments, that is ascites, pleural effusion, pericardial effusion, and skin edema can be there. It may also be associated with the placental edema. Okay. Now significance of positive maternal trypanosome and serology. Okay, we have seen that when there is a trypanosome serology positive in the mother, not all women will be requiring treatment, and maximum 40% patient will require treatment, 60% patient will not be requiring treatment. This is mainly because we have to see whether it is a biologically false positive test. Okay, if it is a biologically false positive test, then the lady will not require treatment. If there is a complete treatment, syphilis is cured before the pregnancy and there is no ongoing high risk, then also she will not require further treatment if there is no reinfection. Okay, so in one of the study they have noted that 46% had been treated adequately for the syphilis before conception. So when there was a positive maternal serology, in that study they noted 46% were treated adequately for syphilis before conception, 23% had a false positive test, and 21 were diagnosed and treated for syphilis for the first time during the current pregnancy. So that was one of the study which they have mentioned. Okay, now coming to the management of positive maternal trypanosome antibody serology. You have screened the patient and the maternal serology is positive. How we are going to manage? Okay, such ladies are to be referred to the genitourinary physician as early as possible. MDT management will involve laboratory role. Then midwifery and obstetric services are to be involved, genitourinary medicine and pediatrics and HIV MDT if the patient is also complicated by the HIV infection. Now, management where syphilis was cured prior to the pregnancy. In that particular case, what is the management? The RPR and VDRL titers should be checked at the first antenatal appointment, and if there is a risk of reinfection, we have to repeat later in the pregnancy. If the RPR and VDRL excludes reinfection, the woman will not require further treatment and there is no need for the neonate to undergo test for syphilis. So if the patient is already cured before, in that particular case, screening will be recommended. Then we have to exclude the reinfection by repeating the test later in the pregnancy. And if we have excluded the reinfection by doing by repeating RPR VDRL, in that particular case there is no treatment indicated for the mother and there is no need for the neonate to undergo test for syphilis. I hope this is clear to you. Okay, now when the treponema test is positive, we have to refer to the fetal medicine also. Maternal referral to the fetal medicine is recommended. At around 26 weeks of gestation, fetal syphilis infection may be suggested by the ultrasound. We have already seen the features on the ultrasound, that is ascites, placentomegaly, hepatosplenomegaly, etc. Fetal assessment will help in planning antepartum care as well as neonatal treatment. So when the maternal treatment is not indicated, when there is a biological false positive test or syphilis is adequately treated before the pregnancy, maternal treatment is not indicated. And maternal treatment will be indicated if there is an active syphilis of any stage, or if there is unclear history of syphilis treated prior to the pregnancy. So previous history of treatment is not clear, then the maternal treatment is indicated. I hope this is clear to you. Now let's see the management of infants which are born to mothers with syphilis. The clinical signs of congenital syphilis we have initially seen. The jaundice, anemia, generalized lymphadenopathy, hepatosplenomegaly, non-human hydrops, pyrexia, failure to move an extremity, that is pseudo-paralysis of parrot, low birth weight. These are the clinical signs of congenital syphilis. There will be skin rash, typical maculopapular, but almost any form of rash is possible. The palms and soles may be in red, mottled and swollen. Vesicles or bullous rash may be present. Okay, so most of the time it is a maculopapular, but vesiculobullous rash is also known to happen in congenital syphilis. Please remember, and it may involve the palms and soles also. Then condyloma lata, very specific, that is flat wart-like plaques in moist areas such as perineum, osteochondritis, periostitis involving the elbows, knees, wrist, ulceration of the nasal mucosa, rhinitis. Snuffles usually present after the first week of life. So combination of these clinical signs and lab tests by Kaufman et al., which we have seen in the previous slides, that will help you to come to a diagnosis of congenital syphilis. Now, what about the neonatal syphilis serological test? All children who are born to the mothers with positive treponema serology will require clinical evaluation and syphilis serological test with the following exceptions. So, mother with biological false positive serology and maternal treatment which is cured prior to the pregnancy will not require further evaluation, while rest of the neonates will require further evaluation. Okay, passively transferred maternal non-treponema antibodies should decline by 3 months of age and it will become negative by 6 months of age, and treponema antibodies will clear by 18 months of age. Okay, so how many months will be required? 6 months for the clearance. 3 months it will decline passively transferred non-treponema antibodies, and treponema antibodies will clear by around 18 months from the neonate, which is passively transferred from the mother. Infants born to mother diagnosed and or treated for syphilis during the present pregnancy will require RPR and VDRL and IgM test at birth and at 3 months of age, and after that 3 monthly until it becomes negative. If this titer remain stable or increase, the child should be evaluated and treated for congenital syphilis. So what we have to do, if there is a history of treatment of the mother during this particular pregnancy, we will carry out RPR and VDRL test on the neonate sample, not on the cord blood. We will do RPR and VDRL on the sample of the neonate. We will also do the IgM test at birth and we will repeat at 3 months of age, and after that 3 monthly till it negative. And in case of infants with suspected congenital syphilis, infants born to mothers treated less than 4 weeks prior to delivery, infants of mothers treated with non-penicillin regimen, infants born to untreated mothers will require evaluation in this particular way. Okay, so this is important from the congenital syphilis point of view. So let's see the recommendation. Children born to mothers treated with syphilis in this pregnancy will require clinical evaluation of syphilis screening serology. Okay, and syphilis serology should include non-treponema titers, that is VDRL, RPR and IgM at birth at 3 months and then 3 monthly until it negative. Okay, passively transferred maternal treponema antibodies will be positive and unhelpful in these circumstances. Untested siblings should be screened for syphilis when a maternal or congenital syphilis is made. So if you have any EMQ, please note down this particular point. The test will be RPR, VDR and IgM test at birth, then at 3 months, then 3 monthly till it becomes negative. Okay, so that is what is the treatment if the mother is received the treatment for syphilis in this current pregnancy. Okay, so you have to find out what exactly is given in this scenario. Early syphilis, we have seen the benzathine penicillin single dose, then additional dose in the third trimester. In early syphilis, that we have seen procaine penicillin, amoxicillin, ceftriaxone, erythromycin and azithromycin are not favored. So this treatment we have covered. Late syphilis also we have covered, so we'll skip this particular slide. Okay, now, neurosyphilis generally not asked in the examination, but here the procaine penicillin is the first they have mentioned before benzyl penicillin. Okay, the dose is high, the treatment is for 14 days. Okay, alternatives again, amoxicillin is there, but the dose is high, 2 gram for 28 days. Oral treatment in neurosyphilis is for 4 weeks. Okay, ceftriaxone dose is high, 2 gram. Okay, and it is for 2 weeks. And most important, steroid should be given with all anti-treponema antibiotics for neurosyphilis, 40 to 60 milligrams of prednisolone OD for 3 days, and we have to start 24 hours before the antibiotics. This also we have seen. Okay, early syphilis, primary, secondary, this is covered. Late syphilis treatment in a non-pregnant stage, so doxy can be used. However, in late syphilis, treatment is for 28 days. Okay, that finishes the today's topic of syphilis. Thank you. Okay, that finishes the today's topic of syphilis. Thank you. Okay, so that finishes today's topic of syphilis in pregnancy. Okay, thank you.